Hello, everyone. Thank you for joining me. Today, we're going to talk about substance abuse and eating disorders in the pre hospital EMS setting. These are two very challenging situations that we as EMS professionals may encounter in the field. In this lecture series, we'll explore what these conditions are, how they affect our patients both psychologically and physically, and how we can approach and care for these patients safely and compassionately. By the end of this talk, you should have a clearer understanding of the signs to look for and the actions to take when faced with a substance abuse or eating disorder emergency. Let's get started. First, let's set the stage with why this topic matters for EMS. Behavioral health emergencies, which include things like overdoses, suicide attempts, psychiatric crises, make up a significant chunk of our 911 calls, roughly 5 to 7% by some estimates. That might not sound huge, but consider that EMS across the country runs millions of calls. 5 to 7% is a lot of patients. And nearly half of those behavioral emergencies involve drugs or alcohol in some way. So, yes, substance abuse is something we see regularly as EMS providers. Eating disorder crises are less common on 911 calls, but when they do happen, they are often life threatening and complex. Importantly, substance use disorders, like drug or alcohol addiction, and eating disorders, like anorexia and bulimia, are among the deadliest mental health conditions out there. In fact, anorexia nervosa has the highest mortality rate of any psychiatric illness other than opioid addiction. Think about that. Untreated anorexia and opioid abuse are both extremely lethal. So, we're dealing with conditions that pose serious risks to our patients' lives. Another reason this is critical, these emergencies blend medical and psychological issues. An overdose patient, for example, needs aggressive medical intervention like airway management and possibly naloxone, but they're also in a fragile mental state and might be confused or combative. An eating disorder patient might have a cardiac dysrhythmia from malnutrition, a clear medical problem, but the underlying cause is psychological, and the patient might be fearful or resistant to care. We, as EMS providers, have to navigate both worlds, providing emergency medical treatment while also managing the scene and the patient's psychological needs. So, during this presentation, we'll divide our focus between substance abuse and eating disorders. We'll discuss what each of these entails, common co occurring mental health issues, warning signs, and what happens in the body. Then, crucially, we'll outline our EMS approach, how to keep the scene safe, how to communicate with these patients, what to assess, how to treat, and how to make transport decisions, including any ethical considerations. I'll also walk through real world EMS scenarios for both a substance abuse call and an eating disorder call to help you visualize how these situations might play out. Our ultimate goal is to start with EMT scope of practice, meaning everything we cover will be something an EMT at the BLS level can understand and act on, and we will add in how the ALS providers supplement the BLS care. We'll incorporate current best practices and evidence where we can so you know you're getting up to date information. All right, let's dive into the first major topic, substance abuse. What do we mean by substance abuse or substance use disorder? In simple terms, it's a condition in which someone is using a psychoactive substance, which could be alcohol, prescription meds, or illicit drugs, in a way that causes harm or distress, and they can't stop despite that harm. It's a pattern of uncontrolled use. For example, someone might start by using a painkiller for an injury, but over time it spirals into taking far more than prescribed, craving it, and continuing use even as their life falls apart. That's a substance use disorder, often abbreviated SUD. This exists on a spectrum. Not everyone we encounter is a full blown addict. You might see patients who are just acutely intoxicated, maybe a teenager who drank too much at a party, versus someone who has a chronic dependence on a substance like heroin. Clinically, we talk about levels use, intoxication, substance use disorder, and substance dependence. But for our purposes, if the substance use is causing a crisis requiring EMS, it's a problem regardless of the exact label. SUD isn't limited to one type of drug. It includes alcohol, which is actually one of the most common substances abused, opioids, like heroin, oxycodone, fentanyl, stimulants, like cocaine, methamphetamine, sedatives, like benzodiazepines, and others. Often people mix substances, for instance, cocaine and alcohol together, or opioids and benzos, which can complicate our assessment because the signs and symptoms can blend. Now, in terms of how big this issue is, it is vast. We're in the midst of what's often called an opioid epidemic. Tens of thousands of people die from opioid overdoses each year. EMS sees these daily. You or your colleagues might have already administered naloxone on calls. And it's not just opioids, alcohol related calls, intoxicated persons, withdrawal seizures, etc. are daily occurrences in many systems, as are calls involving meth or other stimulants leading to bizarre behavior or excited delirium. So, this is core EMS content. We need to be prepared because substance abuse emergencies are a steady part of the job. To summarize, substance abuse refers to a maladaptive pattern of substance use leading to significant impairment or distress. It ranges from casual misuse to full addiction. It's not about what substance as much as how it affects the person's life and health, though different substances do cause different acute presentations, which we'll talk about. And importantly, it is very prevalent. Many of our medical emergencies have a substance use component behind the scenes. Now, let's talk about why addiction happens, the psychological and physiological underpinnings. This is important because it helps us understand patient behavior on scene. Addiction isn't just bad choices, like it's a complex brain disorder. Psychologically, someone might start using a substance for a variety of reasons: curiosity, peer pressure, to feel good, to perform better, etc. But a huge reason, especially as it progresses, is using substances as a coping mechanism. Many people with SUD have underlying emotional pain or mental health struggles: depression, anxiety, trauma, PTSD. Using the substance can temporarily numb emotional pain or relieve stress. For example, a veteran with PTSD might discover that opioids or alcohol blunt their nightmares and anxiety. A survivor of abuse might use stimulants to push away depressive thoughts. In essence, the drug becomes a crutch to cope with life. Over time, the person often loses other coping skills and starts to rely more and more on the substance. Psychologically, they might feel they need it just to feel normal or get through the day. As use continues, it transitions from a voluntary action to a compulsive one. The person often experiences intense cravings, an overpowering urge to use that overrides other thoughts. This is partly psychological and partly physiological, which leads us to the body side of the story. Physiologically, addictive substances literally change the brain. Most drugs flood the brain's reward circuit with dopamine, a neurotransmitter associated with pleasure and reinforcement. This is far beyond normal levels of reward, like the pleasure you get from eating or exercise. The brain learns, wow, that was great, let's do it again. So taking the drug is reinforced strongly. Over time, to adapt to these high dopamine surges, the brain reduces its natural dopamine activity or responsiveness. This means the person develops tolerance. They need more of the drug to get the same high because their brain is less sensitive to it. Also, activities that used to be rewarding, hobbies, relationships, become less satisfying because the drug has essentially hijacked the reward system. Eventually, the body and brain come to depend on the substance's presence to maintain equilibrium. If the person tries to quit or even goes too long between doses, they go into withdrawal, which can involve intense physical and mental symptoms that are often the reverse of the drug's effects. For instance, withdrawing from opioids causes pain, diarrhea, anxiety, the opposite of the pain relief and euphoria opioids cause. Withdrawing from alcohol or benzos can cause overactive nervous system symptoms. Since those substances suppress the CNS, their absence causes rebound agitation, tremors, possibly seizures. The fear of withdrawal, which can feel like a severe flu or worse, and can even be life threatening with some substances, drives people to keep using as well. So at this point, we have a chronic relapsing disease of brain function. The person's control over their use is drastically reduced. They may genuinely want to quit, and many do try multiple times, but their altered brain chemistry plus psychological dependence makes it extremely difficult. This is why addiction is considered a disease, not just a moral failing. It actually changes brain structure and function. Now, why does this matter to us in EMS right now? Understanding this helps us approach these patients without judgment. When an addicted patient says they needed to use or they have cravings, that's real. Their brain is driving them to do it, sometimes against their better judgment. It also helps explain certain behaviors. For example, why a patient might be anxious or agitated if they haven't used. They might be in withdrawal and desperate to use again. Or why simply telling someone to just stop using isn't effective. If only it were that simple. So keep in mind, addiction often starts voluntarily but becomes a compulsive brain driven behavior. Patients are accountable for their actions, yes, but they're also struggling with something that has taken control of their brain's reward circuits. We just discussed how psychological issues often feed into substance use. Indeed, substance use disorders frequently come hand in hand with other mental health conditions. Research shows about half of individuals with a substance use disorder also have had a mental illness like depression, anxiety, bipolar disorder, or PTSD, and vice versa. It's a two-way street. Mental illness can lead people to self-medicate with drugs, and heavy drug use can trigger or worsen mental health issues. So it's not unusual on an EMS call to find that a patient isn't just a drunk or a drug user. They might be a person with untreated depression who drinks, or someone with schizophrenia using drugs to quell their symptoms, etc. Recognizing this can help us be more empathetic and also vigilant. A suicidal overdose patient, for example, has both a substance problem and a psychiatric emergency. Now, what about warning signs and patient presentation? Many of these overlap with what we consider general intoxication signs, but let's lay them out. Physically, different substances have different signatures. Opioids, like heroin, fentanyl, oxycodone. Classic signs are pinpoint pupils, respiratory depression, slow, shallow breathing, and altered mental status, from drowsy to unconscious. You might also see needle track marks on arms or other injection sites if they inject. Skin might be cool and clammy, heart rate and blood pressure often low. They may have signs of long term IV use like scars or infections. Stimulants, cocaine, meth. Opposite of opioids in many ways: dilated pupils, rapid heart rate, high blood pressure, agitation, paranoia, often sweating and overheating. They might be very talkative, or if it's severe, like meth induced psychosis, extremely agitated, even violent, possibly hallucinating. They often have poor dental health, especially meth mouth, and skin sores from picking, alcohol, odor of alcohol, unsteady gait, slurred speech, flushed face. In withdrawal, if that's why we're called, they might have tremors, sweating, and anxiety, or seizures and hallucinations in severe withdrawal, DTs. Benzodiazepines, like Xanax, Valium. Similar to alcohol, drowsiness, slurred speech, perhaps confusion, but pupils usually normal and not much for specific odor. Others, like PCP, hallucinogens, could see bizarre behavior, hallucinations, nystagmus, rapid eye movements in PCP, high pain tolerance, etc. Beyond those acute signs, there are behavioral warning signs of chronic substance abuse that family bystanders might report or you might infer. Neglect of responsibilities, for example, he used to be a great student, now he's failing classes or missing work. Secretiveness or lying about activities. Financial or legal problems, multiple run ins with the law, arrests for DUI or possession. Social changes. Old friends gone, new friend group that also uses, isolating from family. Appearance neglect, malnutrition, not bathing, wearing the same clothes. On scene, you might find paraphernalia, syringes, burnt spoons, rubber tie offs for IV use, pipes, bongs, pill bottles, sometimes with someone else's name, empty alcohol containers, etc. The environment can tell a story, like beer cans all over the living room or a medicine cabinet full of pill bottles. Psychologically, aside from the mental health disorders we mentioned, substance abuse can cause denial. The patient might insist they don't have a problem. I can quit anytime, or I only had 2 beers when clearly intoxicated. Irritability or mood swings. They may be calm 1 minute and yelling the next, especially if questioned about their use. Manipulative behavior. Some may try to manipulate EMS or others to get what they want, like trying to get pain meds from you or refusing care to avoid consequences. Shame and guilt. Alternatively, some patients are very ashamed. You might see this if someone overdosed and then is awake. They may avoid eye contact, cry, or apologize repeatedly. For us as EMS providers, the takeaway is to watch for those signs during your assessment. Does the patient's presentation fit a substance abuse pattern? Are there secondary clues? Pill bottles, bystander comments like, I think he's been using again? Identifying that you're dealing with a likely overdose or intoxication can direct your treatment, like giving naloxone or anticipating a combative awakening. And importantly, it clues you into what kind of approach might be needed, which we'll get into next, because an intoxicated patient requires a certain communication style and safety measures that, say, a cardiac patient might not. We will end this lecture here. Join me in the next one to jump into how EMS approaches this patients and more. See you then.